So next, we are going to be shifting gears to the Kleefstra Clinic at Boston Children's Hospital. And so, we've referenced this a couple of times that we began this initiative 3 years ago when we launched as an organization, is setting up a opportunity um, with having a center of excellence and making sure that we had a dedicated team of individuals who were focusing on KS. And a big part of that has been our next speaker, Zoe Frazier. Zoe has really gone above and beyond, I believe, in her role. She started out with a specific amount of time allotted to focus on the KS clinic, and let me just be abundantly clear that she has far exceeded that. And it's amazing to have someone who is so dedicated to our families and our kids and folks impacted by KS. So, Zoe, I will let you take it from here with your presentation, but thank you for everything you do and looking forward to your presentation.
Awesome. Thank you, Jeff. Thank you for such a nice introduction. Let me go ahead and share my screen. Share these slides. Okay, does that seem, can you see everything?
Perfect.
Okay, great, awesome. So as Jeff said, my name is Zoe Frazier. I'm a genetic counselor who works at Boston Children's Hospital. Specifically, I dedicate a good portion of my time to working with in the Kleefstra Clinic, and I also work in Kleefstra Research. So I'll talk a little bit about both the clinical arm and research arm at Boston Children's. Before I dive in, I want to thank iDefine for hosting this conference and inviting me to present. It's been a fantastic lineup so far, so it's great to be here. So our clinic is located on the east coast of the United States in Boston, Massachusetts. We're a particularly nice place to visit in the spring, summer, fall. Winter's a little bitter and cold, but it's a great place to visit year round. But it's a great place to come not only for the history and the great seafood, but we are known for our medical and biotechnology here in Boston, and specifically Boston Children's Hospital is a world-renowned institution. Our clinic resides within the main campus of the Longwood campus in Boston, particularly in an outpatient building that was recently developed. So our clinic resides in this building. This is what a lot of the clinics look like in the lobbies. But we also have, as this building is opening, more of our clinical partners are actually moving to this building. So a lot of our clinicians are being more centralized. So this means in the past, when families would come see us, they would see Dr. Sid and myself in this building and then have to go a little down the road to see other clinical partners, but things are starting to be a little more centralized here at Children's. So these are our, this is the Kleefstra Clinic team. So the physician who leads the clinic is Siddharth Srivastava, also known as Dr. Sid. He's a pediatric neurologist by training. The other director of the clinic is Dr. Ann O'Donnell, who's a geneticist. She sees patients at Boston Children's and then also leads a group at the Broad Institute and does a lot of genetics research. As you know, my name is Zoe Frazier. I'm a genetic counselor. I'm also the clinical coordinator for our clinic. And we have a variety of clinical partners who also see our patients who come to our clinic. So we have a physician who specializes in psychiatry and otolaryngology, which is ENT, gastroenterology, sleep medicine, ophthalmology. So when we have established patients, we're able to connect them with these clinical partners depending on the concerns that arise throughout a child's life. It's also important to mention that for Dr. Sid and I, different departments have different regulations about age, but we see patients across a whole age spectrum. So we see infants all the way through adulthood. We also have a genetic counseling assistant, Haley Osika, who recently joined our team, and she's starting to help with intakes and coordinating the collection records and the intake process. So our clinic is unique in the sense that it resides within an institution called the Rosamond Stone Zander Translational Neuroscience Center. And the TNC aims to improve the lives of children who are affected with conditions that impact the brain through state-of-the-art and equitable research. This allows research to quickly be moved into clinical practice. So we have the clinic, but there's also a research component and research protocols that I'll go into a little later on, but there's this positive feedback loop between the two arms. So our clinical findings often inform or inspire our research ideas and questions, and then any results that we get from research can actually go back and directly positively impact our clinical patients. So we learn so much from every family who comes to see us in clinic or enrolls in research or both. So we're truly indebted to the families that come to see us, no matter how they wish to contribute to our work. So when thinking about the clinical side of things, as all the families know, Kleefstra syndrome is a highly variable condition. So we like to evaluate each individual and truly assess where every child is. And as I said, this is for Kleefstra syndrome, so specifically loss of function for EHMT1. And during these visits, we create patient-specific care plans for each individual, because every person is unique. And through these plans, we really aim to optimize the potential of each of these children or adults. And then we also, outside of the actual clinic visit, we continue to support families by writing letters of support to, advocate for local services or care. We also collaborate with home care teams. So say something comes up after the visit, or you're not able to come back, for a yearly checkup, but something arises, we're able to collaborate directly with, your local PCP, neurologist, and any specialist that is highly involved in your child's care. We can work with them to try and make sure and support this patient. And then thinking about the research goals in general, I think the whole research community's goal is to better understand Kleefstra syndrome. We're doing this through natural history studies, both past and future, hopefully, neurodevelopmental and sleep assessments, and then biochemical and cellular analyses. But our ultimate goal, whether through our clinical data collection and research, is to become clinical trial ready. That's a goal that I think has been reiterated throughout the last few days, but that's also a common goal that our clinic shares. So thinking about how to become a patient at Boston Children's, this is actually a self-referral process. So your physician can definitely reach out to us via email or phone, but you can also advocate and reach out to us. This is our contact information. You can email or call us. Our contact information will be at the end of my slides, and it can also be found on the iDefine website. Once you contact our team, there will be an intake call with someone from our clinical coordination team, and that is established just to get a better sense of your child, their needs, and how we can best help you. We then help with the scheduling process and collection of records, and then schedule appointments. If you're unable to come to Boston, we still recommend providing your local team with our contact information, because we can still have physician-to-physician conversations and talk about your child with their doctors that know them best. So we're happy to reach out and discuss KS-specific guidances in the context of your child. So to date, we have actually provided, this is a little outdated as of Monday. So we've actually provided clinical care, not research, but just clinical care to 71 patients with Kleefstra syndrome. And this represents the geographical spread of our patients. The next slides will show de-identified aggregate data from our clinic. So like I said, this is a little outdated, 71 patients. But this shows the spread of ages of patients at the time of their visit at Boston Children's. And this also shows the sex breakdown of males and females. I think this slide is particularly important when thinking about the next few slides that I'll show about our common clinical trends that we see, because it's important to appreciate that the majority of our patient population is younger than 10 years old. So as I present this data, I think it's important to note that there are some restrictions. So for example, when thinking about intellectual disability, it's really difficult to administer tests and get clear results for assessing IQ for kids who are younger than elementary school ages. So that is a sizable part of our population. Or thinking about regression, that tends to present during or after puberty, and a lot of our patients haven't gone through puberty yet. So keep that in mind as we think about the data moving forward. I think it's also important to think about why we see this trend. So I think this, the higher level or numbers of patients who are younger compared to adolescence or adulthood speaks to the fact that genetic testing is now becoming more accessible to families. I think there are a lot of, personally, I think there are a lot of people walking around in the world who have Kleefstra syndrome, but these patients were born before variants in EHMT1 were associated with human disease. They were, they might have also variants within EHMT1 that couldn't be detected with the current technology of that day. So I think there's a population of adults with Kleefstra syndrome who have yet to be identified. So this slide just shows a little bit of a breakdown of the variant type that we see. So when we think about Kleefstra syndrome and the cause of Kleefstra syndrome from a genetic perspective, we think about two different categories. So one category are the patients who have a chromosomal deletion at the end of chromosome 9. So a section has been deleted and it contains EHMT1 and sometimes other genes in that region. And the loss of function of that one copy of EHMT1 results in Kleefstra syndrome. The other category is thinking about what we call intragenic variants within EHMT1. So instead of thinking about the chromosomes, if you zoom in and think just about the gene EHMT1, these are variants that arise. They're very small, often very small spelling changes within the EHMT1 gene that impacts how the gene functions. So sometimes these small spelling changes can result in the gene not working properly. So it's making protein, it's kind of working, but it's not giving the correct information, or the spelling change it results in a complete loss of function, so the gene doesn't work at all. So we think about these two different categories. About 39% of our patients have these chromosomal deletions, whereas 61% have the intragenic small variants. And then if you think about within the other category of the intragenic variants, there are different types of spelling changes that can arise. And this just kind of shows the breakdown. The majority of them are frame shift. So it changes the reading frames that mechanisms that make the proteins can read the letters. And this, typically results in a loss of function. But if you're curious and think, what type of variant does my child have? If you go to your genetic test report, oftentimes the report, if you have an intragenic variant, will say, like, this variant is a nonsense variant predicted to result in loss of function. So there's a verbiage often in these reports that talk about the specific type of change that your child may have. Okay, so the next few slides will provide an overview of our clinical data. This isn't a deep dive in every single feature we've observed, but we do plan on publishing more granular data, hopefully in the near future. Some caveats I want to talk about is these are trends that we've seen. So although we're lucky to work with a large cohort of patients, it's often difficult to obtain statistical significance when looking at data when the numbers are so small. So actually for this purpose of analyzing the data, we're focusing on 64 patients. And these are the patients that were able to bring genetic test reports to their evaluation. So this allowed us to look at the genotype, so their genetic findings, and correlate that with their presentation. So like I said, when we think about breaking down those 64, that data of 64 people into, smaller categories, oftentimes those numbers get quite small, and it's hard to get statistical significance from that. And once again, this data reflects clinical data, not data that we've collected through research. But as you can see, there's a high prevalence of intellectual disability or global developmental delay, other neurodevelopmental or neuropsychiatric phenotypes such as autism, ADHD, anxiety, and depression were seen at a higher prevalence, and also language disorder. So that's outside of the speech delays that are often encompassed with global developmental delay. We also see a high rate of hypotonia, so low muscle tone, dysphagia, so difficulty swallowing, microcephaly, a smaller head circumference, skeletal anomalies like scoliosis, and recurrent infections are often reported. So that's respiratory infections most commonly, or ear infections. Those are very common. Thinking about hearing loss. So hearing loss can be seen, there's a variety of different types. You can see kids that have sensorineural hearing loss, conductive hearing loss, sometimes a mixture of both. And then that 16% represents families who have reported hearing loss, and they're currently undergoing evaluations, but hearing loss is a concern. Dr. Sid and Dr. Wiltrout will talk more about, actually in the next talk, about seizure activity and epilepsy in the Kleefstra population. But as expected, we expect to see about 30% of patients develop some type of seizures or epilepsy in their lifetime. But they'll talk more about that. But that's certainly something that we see in our clinic. The next categories that we think about are regression and the associated catatonia. And so when we're thinking about regression in this case, we're thinking about the very classical presentation of during or after puberty, that big block of loss of sleep, so very severe loss of sleep for many, many days, associated with a big decline when it comes to neuropsychiatric features. So regression is obviously a big concern, and we try to track it. It's sometimes hard because it sometimes doesn't present the same way in every single person. So it's a slightly more difficult phenotype to track. And I also want to keep in mind that this 11% is taking into account all of the patients we've seen at Boston Children's, not just those who have gone through puberty or older. So as I mentioned, there's a large population of patients who are still too young to go through the classical regression we think of. Obstructive sleep apnea is a common feature we've seen, but in general, sleep abnormalities is a concern. This doesn't represent the numbers when we think about regression in that sleeplessness. These are more like disrupted sleep, so abnormal sleep patterns, and obstructive sleep apnea. And these findings, I'll talk a little later on, played a role in us thinking about, sleep seems to be a big component of Kleefstra syndrome, and it inspired a research study we're doing now. So that just kind of reflects the model of the TNC. So a feature we've observed in clinic, we're doing research on it, and we hope that it will positively impact the community. It's also common to see congenital heart defects with Kleefstra syndrome. The most common ones that we identified in our clinic were atrial septal defects and ventricular septal defects. These are defects that you're born with, you don't develop later on in life. However, we did notice a small population of adults with Kleefstra syndrome that were diagnosed with cardiac conduction anomalies, specifically arrhythmias. So that's a finding that we're going to keep looking for as we meet more individuals who are adults with Kleefstra syndrome. Also, gastro-GI issues like constipation is a big concern in the community and is something that we certainly see in our patient population. Oops. So this next slide talks about the unique clinical features identified in our patient cohort. And when I say unique, I mean it deviates slightly from what we typically see and what is previously published. So we noticed that we also broke it down based on the total patient population, individuals who have a chromosomal deletion, and individuals who have those small intragenic variants within EHMT1. So one of the first features that we noticed was a population of patients that have low average IQ or borderline intellectual disability, so very mild, if any, intellectual disability. We noticed 9 individuals within our patient population, all of whom had intragenic EHMT1 variants. Another feature we noticed was individuals who are not walking or have very delayed walking. So it's very common to see motor delays in this patient population, but when we think about very delayed, typically by around age 3, we start to see individuals walking. So this subpopulation of 10 people who have not walked or have very delayed walking is something that we want to continue to track. 9 of those individuals had the large chromosomal deletions and 1 has the intragenic variant. Infantile spasms and refractory epilepsy were also features that we thought were more unique and something to follow up on, and that Dr. Sid and Dr. Wiltrout will talk about that in more detail. We also noticed abnormal eye movements, which is not a typical feature for Kleefstra syndrome. And all of those individuals actually had the intragenic EHMT1 variants. And then, as I mentioned, I touched on previously the arrhythmias, the cardiac conduction anomalies. There wasn't a statistical difference. There's only 3 individuals that presented with this, but it's enough that with such a small population, we're going to continue to look at this feature. So this next slide describes the genotype-phenotype trends that we saw within the population. And I want to preface this slide by saying that these trends don't reflect a hard and fast rule when it comes to how your loved one's genetic change might inform their clinical presentation. So we see individuals with either type of genetic change display a wide range of features. And when a patient comes to clinic, we don't shape our expectations for them based on their variant type. We really do not, at this point, we can't predict an individual's future features based on their genetic change. But the reason that we look at these differences is to try to determine, based on their variant type, are there features that a person might be at a higher risk for? If so, how can we better support them prospectively? So that's really the purpose of trying to decipher any differences between the 2 groups. We didn't notice a clear trend between the 2 genetic subgroups, except for the following features. And once again, these are trends. But individuals with the chromosomal deletions had a higher rate of intellectual disability or global developmental delay. We saw a higher rate of epilepsy, cortical visual impairment, and congenital heart defects, so the atrial septal defects and ventricular septal defects. Individuals that had intragenic EHMT1 variants had higher rates of hypotonia, so the low muscle tone, ADHD, those abnormal eye movements, and the lower average IQ or borderline ID feature. So I want to touch briefly on the research that we've done at Boston Children's, past, present, and future. This clearly does not reflect all the current protocols at other institutions. The last few days of this conference have really shown how much is being conducted across the world. And so there are a lot of our colleagues completing very important work, and we hope to continue to contribute to that work. So to date, 23 individuals with Kleefstra syndrome have enrolled in research at Boston Children's alone. And so past research included collaborating with Radboud University with their natural history study. So that study has closed enrollment. Data is coming soon, which is very exciting. But the individuals who enrolled were ages 13 or older, and we really aimed in better understanding the natural history of the condition puberty on. So really looking at regression and olanzapine. So results coming soon. Currently, we are enrolling at Boston Children's alone for a study that is studying how variance in EHMT1 impacts sleep on a behavioral level and a molecular level. So if you choose to enroll in this study, you can complete, there's a range of different ways to participate. You can complete online questionnaires about behavior and sleep, or your child's behavior and sleep. You can wear a Fitbit and complete a sleep diary, or your child would wear the Fitbit, and the adult or caregiver, would complete the sleep diary with them to understand their sleep cycles, their circadian rhythm over the course of 2 weeks. And finally, there's the option to provide or donate a skin biopsy to create fibroblast cell lines, patient-derived cell lines. Also, Kristen Connors talked about this upcoming research project yesterday, but there's a disease concept model project that is soon to start data collection. So that's very exciting. And in the future, we hope to continue to contribute through a larger natural history study. So we want to collect data across the whole age spectrum, not just 13 years and older. We want to continue to contribute to other collaborators' works and our own by creating iPSC lines. The talks that just happened really displayed why having these models are so important, and they should be made accessible to the greater scientific community. We want to help with that initiative. And then also identifying biomarker studies and future potential targets. Overall, all of the research that we're doing and is generally being completed by the research community are like giant pieces of a puzzle that we're starting to put together. We're really trying to be clinical trial ready. And all of these studies package this condition to be, to lead to hopefully a future clinical trial. That's our hope. Okay, so that is my presentation on the Kleefstra Clinic. I just want to thank the community for being so open and eager to work with us. We could not do any of our work without you. We view each family and each patient as a clinical partner in this initiative to improve care and find a therapy. So we're incredibly indebted to all of you, each and every one of you, whether you came to clinic or enrolled in research. We're really grateful that you've entrusted us with your children, and you feel comfortable collaborating with us. So thank you so much. And if you have any questions about our clinic, feel free to email or call us. Yeah.
Thank you, Zoe. There's a couple of questions in the chat that I just wanted to leave for us to kind of pull through. The first one is related to the prevalence in the gender breakdown, whether there was KS has a tendency to be more prevalent in male or female. I have my own thoughts, but just wanted to see what your reaction would be there.
I suspect no. I think that it's often a de novo condition. So de novo is just Latin for a word new. So that means that when Kleefstra syndrome arises, it doesn't discriminate based on, ancestral background or age. It just spontaneously typically arises. So in theory, it should impact, individuals equally, regardless of their sex.
Yeah, it seems, I believe Hans might have touched on it in his presentation as well, that originally they started out thinking this was potentially just focused on females, but as they later found out, as the work progressed, it doesn't know gender, right? And I think we hit home at that a lot, and I think it's worthwhile to keep mentioning that KS doesn't know gender, ethnicity,
Yeah.
age, it is undiscriminatory.
Mhm.
And so, it's all about the accessibility to genetic testing, which is such a hot button topic. But to your point, we know that there is probably thousands of adults walking around with KS that just don't have testing. It wasn't around at that point. And at this point, you know, I don't know if people would necessarily go back. We have, few and far between, we have folks who are coming into the community that are, ages 20 and above. But
Mhm.
predominantly what we're seeing right now is kind of what your data was showing as far as the breakdown is folks 10 and under and even 2 and under. We're seeing a lot more
Yeah.
coming to the mix. So um, there's another question in here just about regression, which I think is a hot button issue. And
Yeah.
there was a question earlier, just asking about the prevalence of the patients actually seen at Boston that were in that classical regression puberty time period, and just quick back of the napkin math, it was around 35% based upon what you've seen so far, and we've seen numbers as high as 50%, depending on what that cohort looks like. Again, when you're talking about these smaller sample sizes, it's hard to really zoom in too tight on this. But the question that still remains is in relation to regression, is this more of a behavioral emotional regression, or is it a physical regression? And would love just to get context for the community there.
I would say I think it's more of a behavioral regression. It's harder, as you just touched on, Jeff, there's a wide, I think there's probably a wider spectrum of what a regression can be, but typically in the more classical presentation, it's a behavioral regression. Yeah.
Yeah, I think it's complicated. I've long said
Complicated
I
though.
don't necessarily love the word regression. I don't think it's I think it's too broad, right? I think it's we're working with what we got to a degree right there. But I think as
Exactly.
we continue to do these things like the natural history study, we're able to hone in a little bit further and really kind of extract what this is. I mean, certainly there was a follow up there about cognition. What I've seen anecdotally within the community is around behavioral, some mental disorders, breakdowns,
Yeah.
psychosis, sleep, right? And so I think all of those things probably interact with the physical component, right? Where
Mhm.
there's just a little bit more uh, uh, lethargicness, I guess, for the lack of a better word, where
Yeah.
there's just not that like get up and go get them. Where maybe when the kids are younger, I'm like, I know my daughter, he does not stop moving, right? So I think you can see kind of a clear delineation in the physical activity as this period happens. But again, this is just to kind of reinforce and drive home more about the data and contributing to studies. Like, this is where the community is that important piece that without it, a lot of these questions will continue to linger unless we're contributing.